So good morning, everyone, and thank you for joining this event on ethnic inequalities in healthcare for people with multiple long-term conditions. My name is Laia Beccaris. I am Professor of Social Science and Health at King's College London, and together with my Stafford, who is Senior Analytical Manager in the Data Analytics team at the Health Foundation, I lead a project on ethnic inequalities in healthcare for people with multiple long-term conditions. And in this project, we have found stark ethnic inequities in the prevalence of multiple long-term conditions. So we find that people from Black African, Black Caribbean, Black other, and mixed ethnic groups are more likely than white majority populations to have two or more long-term conditions. And we find that these ethnic inequities expand with age. So ethnic inequities magnify as people grow older. And we have also found ethnic inequities in healthcare outcomes for people with multiple long-term conditions. So we find that people from Bangladeshi, Pakistani, Black Caribbean, and Black African and Black other ethnic groups have worse healthcare outcomes compared to white people with multiple long-term conditions. And Brenda Hayanga will talk more about the findings from our project, but I just wanted to give you a background behind our motivation for developing or for putting together this event. So this event focuses on ethnic inequities in healthcare for people with multiple long-term conditions, and we have put together 5 really excellent presentations from really complementary and different speakers who will provide different angles on this issue of ethnic inequities in healthcare for people with multiple long-term conditions. And we have a really tight agenda, really packed agenda. If I can move the screen. So we will first hear from Habib Naqvi, who is director of the NHS Race and Health Observatory, who will talk about tackling the causes of the causes behind ethnic inequities in multiple long-term conditions. Then we will hear from Brenda Hayanga, who's a research fellow at King's College London and the researcher on this project. And Brenda will present on ethnic inequalities in healthcare and care quality among people with long-term conditions. Then we will hear from Jay Dasmunshi, who's a clinical reader at King's College London, and she will be presenting on her research on ethnic inequalities in severe mental health and long-term conditions. And then we will hear from Eve Riley, who's a program manager at the Richmond Group of Charities, who will present findings from a qualitative study on the lived experiences of people with multiple long-term conditions. And finally, we will hear from Jabir Bhatt, who's Chief Executive of the Race Equality Foundation, who will provide key reflections on tackling racial inequality in healthcare. And as you can see, we have different Q&A sessions scattered across the event. And we ask you to please post these questions either in the chat function or the Q&A function. And then my staffer will be leading the Q&A, and she will pick up key themes in the questions that you pose. So I am chairing the event, and I will keep to time because we have a lot of ground to cover in under 2 hours. So I will pass the mic on to Catherine Merrifield, who is Assistant Director in the Healthy Lives team within the Health Foundation, who will provide some opening remarks. So I will.
Thank you ever so much, Laia. I'm really pleased to be here today. I think it's going to be a really great event. And yeah, just really pleased to be able to say at the start a little bit about the Health Foundation and why we've been involved in the work. I think we've got some slides which will hopefully be with us shortly. So just for those of you who don't know, the Health Foundation, we are an independent charitable foundation. Our vision is about improving health and healthcare in this country. And we're in the really lucky position of having an endowment of around £1 billion to support us in achieving that mission. Going on to slide 2, at the heart of all of the work that we do, particularly in the Healthy Lives team, next slide, please, thank you. At the heart of all of our work is an understanding that an individual's health is shaped by a range of factors, which are set out on this slide. So including early life, the work we do, the income we earn, the education we receive, and the homes and places we live in. And because of variations in how we experience these things, we see deep inequalities in health outcomes between different people and places in our country. I think that's helpful to set it out at the beginning, because I think in the context of this conversation, we know that these building blocks of good health, things like housing and education and employment, are often weak or missing for people from minority ethnic groups. And we also know that structural racism, discrimination, and associated trauma are also a negative determinant faced by some populations. This in turn has led to a lack of trust by some in statutory services, which isn't helped by services lacking cultural awareness and lacking links with community organisations. And so this is why we're here today, to talk about the significant variations in health outcomes that result from these building blocks and these wider factors. I'm sure we're going to see lots and lots of fascinating charts this morning, but just to start us off, if we could just go to the next slide, where we've got a chart from some research that we've done at the Health Foundation. And it shows that when we standardise for different age distributions across ethnicities, we find higher levels of diagnosed ill health in Pakistani, Bangladeshi and Black Caribbean people than among the white population, as we've just heard in the introduction. And it's worth just saying that a higher score on the index that is used in this chart means a higher risk of future healthcare use and premature death. So again, we can see really stark differences there. But I think it's important to say that while, as I've said, wider determinants of health are absolutely critical for preventing ill health, there's obviously this really critical and essential role for healthcare services once people have long-term conditions. And I know we'll be looking at that more during the session. Moving on to the next slide, I just wanted to show, which breaks down that index into a bit more detail. So you see the differing rates of specific diagnosed illnesses for people from different ethnic minority backgrounds. So there's a lot going on in this chart, but worth just pointing out that people from Pakistani and Bangladeshi ethnic backgrounds in England have got the highest age standardised rates of chronic pain, diabetes, dementia and cardiovascular disease. The white population have got the highest rates of diagnosed atrial fibrillation, which is an important risk factor for cardiovascular disease that can lead to preventative intervention in primary care. So there's some quite interesting points there about levels of diagnosed illness that can actually be picked up earlier on, and therefore a different role for healthcare services. So worth pointing out as well that these figures are based on diagnosed illnesses, and we do know that access and presentation for care is at different levels for different population groups. So there's likely to be an underreporting for certain groups. But I just wanted to set these out at the beginning because I think it paints quite a clear picture around how people from different ethnic minority groups are experiencing ill health as a result of disadvantage and discrimination. The final thing I just wanted to say was, at the Health Foundation, we've obviously been really delighted to be involved in this programme, but it doesn't end here for us. We're in the process within the Healthy Lives team of developing some work with the Runnymede Trust to really dig into different experiences of these wider determinants of health for different population groups. And that will really help us to build our understanding of racialised health inequalities and the wider social and economic forces, and also healthcare services that influence those outcomes. So do look out for that. But I think I'm within time, so I'm going to hand back to Laia for the rest of the presentations. Thank you very much.
Oh, Laia, you're muted.
Sorry, I just gave really clever remarks. Sorry, I was going to say thank you, Catherine, and I'll pass on to Habib Nagbe, who's director of the NHS Race and Health Observatory.
Brilliant. Thank you, Laia, and thank you, Catherine, for the introduction. As I share my screen, as the title of my presentation states, I'll be looking at the causes of the inequalities that we see. And I guess I always start by looking at the background to this and the fundamental point that health inequalities are unfair, they're immoral, and they're wrong, and yet they're avoidable. And that, I guess, is the sad story of ethnic health inequalities. And the fact is that these differences that we see, this stratification that we see in terms of access, in terms of experience of healthcare, and in terms of obviously outcomes, are there and have been there across a range of areas as diverse as genetic counselling, artificial intelligence, and maternal health. And yes, these disparities are set against a higher prevalence of specific health conditions, whether that's cancer, whether that's cardiovascular disease, whether that's diabetes. And of course, what we've seen over the last 3 years, nearly 3 years now, is the disproportionate impact of a pandemic, COVID-19, on our ethnic minority communities and ethnic minority health and social care staff as well. So there is a level of urgency for us to focus on this area. And in a way, it can be argued that our country and our healthcare system should be well equipped to deal with this level of urgency for a number of reasons. One being the fact that we have a long history of migration in this country that goes back not just decades, but centuries, and we therefore have large and growing ethnic minority communities. Secondly, we have fairly robust legal frameworks in the Equality Act and the Health Inequalities duties. And thirdly, there has always been a huge investment in healthcare research, just as Catherine's highlighted, for example, from the Health Foundation and many other organizations as well, which are doing a lot of good work as well. And at the same time, I guess it can also be argued that our collective responses to tackling ethnic health inequalities have been somewhat costly, confused, and fragmented, in the sense that many of these approaches look at surface level issues without focusing on the title of my presentation, the causes of the inequalities that we see. And that does include the role of racism in healthcare, structural racism, interpersonal racism, and how those two also interact in relation to institutional racism that we see within our organizations and that we see within healthcare organizations as well. We saw only last Monday the Women and Equalities Committee report on maternal health, highlighting the kind of the underplay of the role of racism in maternal health outcomes. Just as one example of the kind of very long list of issues and examples that we have with regards to looking at the fundamental issues. And in fact, it was the special edition of the BMJ in February 2020, I believe, entitled Racism in Medicine, that led to the origins of the NHS Race and Health Observatory itself. And a very strong argument was put in that special edition of the BMJ, which was guest edited by Lord Victor Adeboali and Professor Mala Rao, looking at the fundamental reasons why the establishment of an independent race and health observatory is important, so that it can focus on those causes of the causes and hold up a mirror to the rest of the healthcare system with regards to what needs to happen as we move forward. And 2 years into our work, we are now looking at a range of different areas, from maternal health and neonatal health. I mean, it cannot be right that today in 2023, Black women are up to 4 to 5 times more likely to die during pregnancy, childbirth, Asian women being up to 2 times more likely. And we've seen so vividly the higher rates of stillbirths among certain communities as well. And then, of course, mental health. And we all know of the stark statistics around mental health and ethnic minority communities. We've been focusing on COVID-19 for obvious reasons, the uptake of the vaccine. We've been looking at, and we are continually looking at sickle cell disease and the care pathways for sickle cell, innovation, genetic testing, genomics, looking at the NHS app, independent review that we published recently around the NHS app is just another example of that. And of course, if we're in the business of tackling health inequalities, which we are, then we need to create equitable environments as well. And that includes ensuring that we have diversity within our healthcare workforce, and not just diversity, but inclusion as well, because we know that diversity is not necessarily a precursor for inclusion within environments and within organizations. And if we're looking at the causes of the inequalities that we see, then we must look at diversifying healthcare research, not just what's researched, but who leads the research, as well as diversifying education, what gets taught within undergrad, postgrad degrees, what doesn't feature within textbooks, etc. And then I always say, and my vision for the observatory has always been to be global. And we were pleased within the first year of our establishment to have a twinning relationship with the Center for Disease Control in the US, the CDC, on the back of the G7 summit 18 months ago. And we're developing now a joint work program with the US around some of these areas as well. The way we operate in terms of the causes is to focus on 3 stages of our operating model. Firstly, bringing together the evidence base where it exists, or establishing it where it doesn't exist. Secondly, turning that evidence into policy recommendations for change. And thirdly, enabling transformation, enabling change on the ground. And if I give you a very quick example of that, the very first piece of work that we did was to look at racial bias in pulse oximetry. And we did so by bringing together the evidence base as it existed at the time, which was just over a year ago. We put forward very clear recommendations for various bodies, including NHS England, NIHR, the MHRA, which is the devices regulatory body. And then we supported those organizations to take forward the recommendations. And on the back of our report, the NHS England updated their guidance on the NHS Choices website around pulse oximetry. And NIHR put out a good call for further research in this area. And the Secretary of State for Health and Social Care announced an independent review into racial bias in medical devices. So those are the 3 stages of our operating model. We've been doing a lot of the first 2 stages, the insight, the research, and the policy. We are also now turning our attention towards enabling transformation. And we're doing that through a number of ways. We're developing our own model of transformation and implementation to support systems. And we're also working with the Health Foundation and the Institute for Healthcare Improvement in a joint program of work looking at anti-racism with regards to improvement and improvement methodology as we move forward. We also, last year, remember this, it was on Valentine's Day, on the 14th of February, published this report, which in fact Laia was involved in as well. And this report was a rapid review into ethnic inequalities in healthcare. It was partly in response to, at the time, the CRED report and the Commission for Racial Equality and Diversity, I think, that the government independently commissioned, but it was also commissioned, this piece of work was also commissioned to help us think about the areas of work that the observatory would want to focus on during its first 2 or 3 years. And this report did make the front pages of The Guardian, and what did come up in question time in Parliament for a number of reasons. Not because it was just another ethnic inequalities in healthcare rapid evidence review. There have been many of those in the past, but because it was focusing on the causes of the inequalities that we see, including looking at structural issues with regards to discrimination and bias. So today, we have nearly 20 programs of work that are currently live. A number of these are highlighted here, ranging from long COVID, ethnicity coding, to looking at mental health care for Gypsy, Roma, traveller communities, looking at learning disabilities and access to healthcare, looking at genetic testing with regards to a specific anti-cancer drug, DPD, where the drug doesn't get broken down in black bodies as quickly as it does in white bodies, and has led to higher levels of toxicity and death amongst certain communities. So we're looking at genetic testing with regards to that. We've looked at elective backlogs, and we're looking at sickle cell disease and the care pathways for sickle cell as well. I highlight this slide because I think it's really important. It's some work that we did in collaboration with the Race Equality Foundation and Jabir's organization, and Jabir will be talking a little later on, because I think it's fundamental. It's about engagement. It's about making sure that we engage in a sustained and meaningful way. And it's about looking at the language and the power of the language that we use to describe different communities. This report has some fundamental principles that we are using within the observatory, and I know are being picked up by many NHS organisations around terminology across the healthcare system as well. I won't go into too much depth, conscious of time. This was a piece of work we did with the King's Fund, looking at leadership responsibility on this topic. The fundamental points being that, yes, we need representation, we need diversity and inclusion with regards to our leadership within the NHS. We need investment, we need to focus on resources, but the fundamental point, number 6, being that we need to focus on the root causes of the inequalities that we see. And that means leaders making sure that their own moral compass is pointing in the right direction with regards to this topic. And those leaders being supported to take the right action at the right time. These are some of the publications that we've been involved with over the last few months. We've got a number of reports coming out, in fact, over the next few weeks, including the Learning Disabilities report. Again, the work that the Race Equality Foundation is supporting us with on that, as well as what will be, I believe, an interesting report looking at neonatal testing and skin colour with regards to neonatal testing as well. So I'll pause there because I'm sure we'll pick up some points in the Q&A a bit later on, and I'll stop sharing my screen and hand over to back to Laia.
That was very useful. And I think very important for this event to center the cause of ethnic inequities and the addressing of ethnic inequities around racism as the key driver, as the key cause. So I want to now pass the mic to Brenda Hyanga. Thank you, Brenda.
I'll just share my screen and right. Okay, can everybody see that?
Yes.
Oh, perfect. I'll just minimize that too. Right, so for those of you who've just joined in, I'm Brenda Hyanga, and I'm a research fellow working on the project on ethnic inequalities in healthcare and care quality amongst people with multiple conditions. And I'm working on this project with Dr. Mai Stafford and Professor Laia Beckeres, and the project is funded by the Health Foundation. So in this 10-minute slot, I wanted to focus on some of the key findings from the project that Laia started off rallying at the beginning. Throughout the presentation, you'll see these QR codes on the slides where you can scan, and then it will lead you to publications or to websites for further information, because I'll just be focusing on the key findings today. Right, so this project is a 3-year project that started off in October 2020, and the aim was to understand whether there are ethnic inequalities in healthcare among people with multiple conditions and identify where care could be improved and ethnic inequalities addressed. So to address this overall aim, we first systematically reviewed and summarized existing evidence on the prevalence of multiple conditions and healthcare use and care quality amongst people with multiple conditions to try to find out whether there are any inequalities there. We also use data from the Clinical Practice Research Data Link and the GP Patient Survey to address questions around the number of long-term conditions, the impact of multiple conditions, and care quality for people with multiple conditions, and whether this was the same across ethnic groups. So far, this is what we found. Like, for instance, the systematic review that we conducted first has identified that existing UK studies point to ethnic inequalities and how common multiple conditions are. The studies that we identified actually included vulnerable populations that were at risk, for instance, the Black, South Asian, and other ethnic groups that had a higher prevalence of not just multimorbidity, but also cardiovascular morbidity when we compared them to the white ethnic groups. There were some studies actually that disaggregate these ethnic groups. And in these particular groups, they found that among people of Black African, Black Caribbean, Black other, and mixed ethnicity, they were at higher risk of multiple conditions compared to their white counterparts. In some studies, they looked at index conditions, for instance, renal disease or diabetes. And for instance, one study found that Afro-Caribbean people with diabetes were reported to be at a higher risk of microvascular complications when we compare them to white people. This review highlighted a number of challenges in working with data, especially when we're looking at ethnic inequalities in multiple conditions. And some of them include the aggregation or the exclusion of some ethnic groups, which then means that we're underestimating some of these inequalities that we're observing. Now, the second systematic review that we conducted has also highlighted fewer studies than the first review that I've just presented, but we identified that some studies that provide evidence of ethnic inequalities in disease management and also in hospital admission among people with multiple conditions. We found studies that reported that compared to South Asian people and white people, Black people with multiple conditions were more likely to have poorer control of blood pressure, total serum cholesterol levels, lysated hemoglobin levels. Black women who had previously abnormal smears were reported to have lower rates of cervical smear rates when compared to white women. And there were a few studies in this review. However, there was one study that focused on children and young people, and it identified that Black and South Asian children and young people had these increased rates of emergency admission when compared to their white counterparts. These particular findings, they suggest that for some minoritized ethnic group populations with multiple conditions, there may be these inadequate initiatives for managing multiple conditions. And so there is a need for these strategies to try and reduce ethnic inequalities in healthcare. Now, concerning the question as to whether the number of long-term conditions was the same across ethnic groups, we find that the number of conditions is not the same across ethnic groups and that there are differences across different age groups. In this analysis, we worked with Dr. Catherine Saunders from the University of Cambridge using data from the GP patient survey and the clinical practice research data link to try and examine inequalities in age-related patterns of multiple long-term conditions. This analysis suggests that inequalities in multiple conditions emerge from midlife, and as can be seen in this figure, by older life, older Pakistani, Bangladeshi, Indian, we had people of other ethnic groups and Caribbean groups had more long-term conditions when compared to their white counterparts. The analysis using the GPPS data was quite useful in helping us to identify vulnerable groups within the white ethnic group. And we found that the Gypsy and Irish travelers had higher levels of multiple conditions at all age groups when we compare them to the white British group. In contrast, we've got groups like the Chinese population who had lower levels of multiple conditions than their white British counterparts. Now, and concerning the questions as to whether multiple conditions and the impact of multiple conditions is the same across ethnic groups, the answer is no, it is not. Dr. Stafford and colleagues at the Health Foundation examined whether the associations between multiple conditions and mortality varied across ethnic groups using data from the clinical practice research data link. And one of the key findings was that for each additional condition, it's associated with an increased mortality, but this association is actually bigger amongst the Pakistani, the Black Caribbean, and Black African groups, as well as the other Black groups. The mortality rate per additional condition at age 50 was 1.33 for the white ethnic group. This means that the number of deaths was 1.33 times that of the group with one less condition at any one point. The mortality rates per condition were 1.43 and 1.78 for the Black Caribbean and other Black ethnicity, respectively. Now, we looked at domains of care quality, but we focused on two domains of care quality. First was relational continuity of care. This is defined as the ongoing therapeutic relationship between a patient and a practitioner. Continuity of care is actually associated with positive health outcomes if we consider that it's associated with lower mortality, fewer hospital admissions, and higher patient satisfaction. We also looked at personal care adjustments. These are formally known as exception reporting. Just a bit of context on this. We know that GPs in England, they voluntarily take part in the Quality and Outcomes Framework, and this is a program to resource and reward good practice. And some patients aren't actually included in this statistic program because they are considered either unsuitable for instance, let's say if they've got complex care needs or that they're frail or they require a different approach to treatment. Or some of them might opt out because then they don't want to take part, let's say if they don't want to have that particular treatment or the intervention that's being offered. And this is known as informed dissent. So we focused on these two particular domains of care quality. Now, concerning the relational continuity of care, in this paper, we looked at whether we could describe the relational continuity of care in general practice by ethnicity and by long-term conditions. One of the key findings was that continuity of care was lower for people living in deprived areas and for certain groups, the Bangladeshi, the Pakistani, the Black African, Black Caribbean, and other Black background. However, continuity of care was higher for the Indian and for the Chinese ethnic groups. And these patterns were actually similar for people with multiple conditions as well. Now, when we examined whether the patterns of PCA reporting was, whether they varied by ethnic group or whether these could be explained by factors such as age, gender, additional conditions, and deprivation, we found that out of the 6 ethnic groups of the 10 minoritized ethnic groups, they tended to have, they were less likely to have a record for informed dissent. Now, this particular finding is quite interesting just for the fact that we do have these narratives that people from minoritized ethnic groups tend to refuse treatment, but it also raises these questions as to about patient disempowerment and what's actually happening within that patient-practitioner relationship, and we need further studies to untangle that. In terms of the patient unsuitability, we found that patient unsuitability was higher among people of Black Caribbean, Black other, and Pakistani ethnicity. And these differences were accounted for by the number of long-term conditions and socioeconomic deprivation in the populations in this particular group. Now, just to sum up, we know that for the findings that we have so far, they do tell us that there are sizable numbers of people from minority ethnic backgrounds who are living with multiple long-term conditions. Within the healthcare setting, there may be opportunities to target clinical and self-management support for people with multiple conditions from minoritized ethnic groups. In relation to the finding for continuity of care, we know that it's valued by patients and GPs alike, yet this research shows that continuity of care is less available to some minoritized ethnic groups, including those with multiple long-term conditions. Now, when it comes to exclusion from the Quality and Outcomes Framework, it means that if we're excluding people from the QOF framework, then we're less able to have this high quality intelligence that leads to improved healthcare, which at best can maintain the state of health inequalities, and at worst, it exacerbates them. As Habib and Catherine have noted, that these mechanisms underlying the observed ethnic inequalities are the result of the interplay of several processes, including those wider processes such as racism and discrimination. And so we need studies to examine the role of these wider societal and structural factors that lead to the development and the exacerbation of ethnic inequalities in health and care for people with multiple conditions. And this also includes looking at the demand and supply of healthcare staff. So I'll stop right there and hand back to Laya. And second, here we go.
I'll hand on to for the Q&A session.
Right, okay, we have got quite a lot of questions. Some of them we might possibly leave till the wider discussion later, but first of all, question on our focus really. So shouldn't we be focusing on prevention rather than treating those that are already ill? So I don't know if Habib or Brenda would like to come in on that.
Yeah, I mean, I'm not sure whether Brenda, you want to go first?
Yeah, I'll go first and then you can follow Habib. So I think it is important for us to focus on prevention. However, we also need to highlight that we don't know everything about the people who are actually ill, as we've indicated, that we've identified ethnic inequalities in the number of long-term conditions, in the impact and care quality. But we still need to find out about the root causes and the underlying causes of how it's affecting all these individuals. So if there's a way that we could balance it, yes, we look at the people with the conditions already and try and improve their health outcomes. We still need studies to underlie how best to support them, while also at the same time having strategies to prevent people from falling into illness, and then these change to multiple long-term conditions.
Yeah, and I totally agree with that. More research is needed, and I guess if, as the latest data and information show, that 74% of household income is going towards healthy eating, then what implications does that have for our definition of prevention? What implications does that have for our thinking around the wider causes of the inequalities that we see? So there is something about understanding the role with regards to prevention that the healthcare system can play, and it's an important role, but it's not the only enabler for equity. It's not the only enabler for us to think about closing down the gaps that we see with regards to later on in life and experience and outcomes.
Thanks. So there's also a couple of specific questions for each of you, so maybe we'll take those now as well. And Habib, have you got any recommendations on some of the priorities that you've identified? Any examples of best practice? Maybe that's something that you can say now or point us to some of those resources. And then Brenda, I'll come to you in a minute and ask, have you considered socioeconomic deprivation in this work? And how does that fit in with what you've been finding? So yeah, could we go to Habib first?
Yeah, I think the priority for me is learning lessons from COVID. So we heard a lot of pledges and a lot of commitments over the last 3 years from people, organizations around the importance of this agenda, the importance of looking at the ethnic inequalities that we see, the importance of looking at the levels of bias and the disproportionate impact. But the question, I guess, is, will those commitments and will those pledges be followed through, or will we fall back into the status quo? And what does follow through mean? It means, as I mentioned before, it means looking at our own moral compass. It means looking at focusing on those underlying causes of the inequalities that we see. It also means focusing on the concept of trust. Trust is, as we saw over the last 3 years, is fast becoming a new determinant of health, influencing people's decisions around whether or not to take up a health intervention. And we saw that with regards to COVID vaccine, for example, but it's not just restricted to the COVID vaccine. So there is an urgency for our healthcare system and for society as a whole to focus on building and rebuilding levels of trust in our institutions.
Maybe that's something we'll also pick up on later in the discussion. Brenda, would you like to say a bit about how you thought about socioeconomic deprivation in the analysis that you've done?
It is a factor that we have considered actually in the paper that we're talking about, the age-related patterns of multiple conditions. These findings that we found that, from midlife onwards, we're seeing particular groups being at risk of multiple long-term conditions. These were adjusted for IMD, but they're also adjusted for gender as well. So this is even after we account for this, we're still seeing these inequalities. In the paper that the analysis that we did in relation to the personalized care adjustments, after we adjusted for age and gender, we found that the Pakistani and the Black, some of the Black ethnic groups tended to have, they're more likely to have a PCA record for being unsuitable. But then these were then explained by the socioeconomic factors, because when we adjusted for IMD, and as well as these the comorbidities as well. So I think one thing that is pointed out here is the interconnectedness of these inequalities with the SES or domains of deprivation. It would be interesting for us to look at other factors of deprivation, but it is something that we have adjusted, and we can't untangle those two, the interrelatedness of them both. So yes, it's something that we've considered for sure.
Thanks. I'm aware of time, so I think, Laia, can I hand back to you now, and I'll save some of the questions for later, if that's okay.
Yeah, that's great. So thank you for posing questions in the Q&A chat. And now I'd like to hand over to Jade Munshi. You're muted, Jay.
Ah, okay. Can you hear me now?
Yeah.
Great, and you can see my slides. Great, okay, thanks very much. It's a real privilege to be able to join you all today for this session around multimorbidities and mental health. So in case you're just joining, my name is Jade Munshi. I'm a clinician, I'm a consultant psychiatrist and a researcher at King's College London, working in this area, and my session therefore is going to focus very much on mental health in that sort of as one of the conditions of multimorbidities. But I'm going to in particular focus in on, oh, are my slides changing?
No, you have the main slide.
Ah, okay, let me just see if I can, oh, there we go, has it changed? Yeah, there's a bit of a delay there, okay. But what I'm going to do actually is put out a challenge that maybe people want to pick up, maybe in the discussion later. Now, I don't think mental health is just another condition that we should be thinking about in a similar sort of way of some of the other conditions. I think people that are living with mental health problems have additional challenges linked up with discrimination and other overlapping forms of disadvantage that are actually fairly similar to some of the other issues that have been raised already. And so we need to think about this in a slightly different way. And what I'm going to do in the next 10 minutes or so is set out some of the work that we've done in some Health Foundation work, Health Foundation funded work around severe mental illness and physical health and the sort of interplay of the two. And then I'm going to go on to talk a little bit about the impact of COVID-19, which I think was also raised earlier by Habib. So let me start off by showing you this figure. So this is a figure that shows life expectancy in the UK for the general population, and it paints a really rosy picture. So basically the red line shows women in the general population living longer. The blue line shows men in the general population living longer. Now look at what happens when we think about people with severe mental health conditions. These are conditions such as schizophrenia or bipolar affect disorders. Some commentators have also gone further and said anybody in contact with secondary mental health care might come under this definition. And we see that people with severe mental health conditions, so women with severe mental illnesses, die 15 to 20 years earlier than the general population, and men with severe mental illnesses die 15 to 20 years earlier than the general population. So these are really, really stark inequities that impact this group of people. It's so bad that the spots have fallen off the figure altogether. And really what underlies this is a broader concern that mental health isn't given the same sort of status as physical health. And there's a lack of parity of esteem, in effect, that plays out. And then you see it in these sorts of statistics. And we see this in terms of how funding, for example, is allocated. Mental health services get lower proportionately lower funded levels of funding than physical health services. And in real terms, for people living with these conditions, they experience it in terms of stigmatizing attitudes towards mental health, specific forms of discrimination that then have an impact in terms of how they're accessing services and so on. So this is really important to think about. And actually this gap in life expectancy is actually on par with when we're thinking about inclusion health. So we're thinking about groups who are socially excluded in general. So for example, through homelessness or through being in contact with the criminal justice system or people living with addictions, this gap in life expectancy is on par with that. And I'm going to argue that when we're thinking about mental health, and particularly severe mental health problems, we do need to be thinking about dimensions related to social exclusion. So we did a piece of work to really map out how this would play out by ethnicity, so disaggregated by ethnicity. And this is a piece of work using data from secondary care. And what you can see here, if you look within the circle that I've just put on there, in the general population, men and women in the general population live longer. When we disaggregate by ethnicity, we see that there's an 11 to 17 year gap in life expectancy across all of the racially minoritized groups and in the white British group. And so in a way, severe mental health problems cross-cut some of the other dimensions of inequities that we know play out. And this is important because I'm going to go on to show you that it sort of overlaps when we start to look at this. I'll focus in on diabetes in particular as a sort of case study. We know that diabetes is more prevalent in people with severe mental health problems. So in this figure, you can see it's about 2 to 3-fold more common in people with schizophrenia and bipolar affective disorders. So we wanted to really see how this played out when we thought about, again, ethnically diverse populations. So in a study taking data from primary care, we looked at the prevalence of diabetes in people with severe mental illnesses. And in this relatively young age group of 18 to 34, you can see that the prevalence of diabetes in people with severe mental illnesses is already higher than those who don't have a severe mental illness shown in the blue. But as we go up in age, that gap gets wider and actually starts to really come apart. And this really picks up what I think Brenda was also sort of raising and has been raised elsewhere, that we need to be thinking about age, we need to be thinking about ethnicity, and in this case, we definitely need to be thinking about severe mental illnesses. So, and again, I think this was picked up a bit by Brenda. We then went on to look at how healthcare is delivered for these groups of people. And actually what we found initially is that if people have a severe mental health problem with diabetes, they have slightly improved glycemic control compared to people who just have diabetes. And so this data comes from primary care. And in primary care, certainly at the time of this study, there is a pay for performance scheme that operates, known as the Quality Outcomes Framework, whereby general practitioners are financially rewarded to operate, for example, a register of people with severe mental health problems and then to offer annual health checks. And so, one might hope or assume that the Quality Outcomes Framework is actually doing what it's meant to do, which is to improve glycemic control in people living with severe mental illnesses effectively. However, when we looked a bit further in the data, we found some inequities. And again, this really picks up from what Brenda was saying a bit earlier. So there are still differences by ethnicity. So in people with severe mental illnesses and type 2 diabetes mellitus, glycemic control was a bit poorer, particularly for the Indian and the Chinese group in our study. And then we also looked at exception reporting. So this is where, if you just joined, this is where general practitioners may exclude people from the scheme in order to, because otherwise they may overall get financially penalised. But what we found is that the very people who are being excluded from the scheme have the worst outcomes. And so we argue that, in fact, what we need to be doing is thinking about outreach to bring in people who need health checks and so on, rather than excluding. So I'm going to move on briefly to COVID-19, again, just raised briefly by Habib earlier, but in January, on the 30th of January 2020, the WHO, as we know, declared a public health emergency of international concern. And what then followed was a lot of quite distressing and really stark headlines in the papers that really highlighted how racially minoritized people were particularly at risk. And we now know from work done by Laia and other colleagues that structural racism and discrimination really played a role. So in some ways, COVID-19 crystallized and brought to the fore inequities that were already there, and made things even worse. And we wanted to just see how this played out when we thought about mental health. And so in this study, we used data just coming up to the pandemic. The red line you can see on those figures is when WHO declared a public health emergency of international concern. And then after that line is data that shows mortality. And here we've compared mortality, taking into account age and gender, in people in contact with secondary care, mental health care services, compared to the general population. And what you can kind of see is that going into the pandemic already across each of the racially minoritized groups and in white British people, the standardized mortality ratios were already elevated, and they got even worse when the pandemic happened. And then when we broke it down by cause, you see that deaths from all other causes were a problem and in excess in people with severe mental health problems prior to the pandemic, and carried on being a concern during the pandemic. And then on top of that, COVID-19 came into play. And the story here, again, what we now know is that there's some major inequities that further widened the gap, particularly in the early stage of the pandemic, where we heard accounts of personal protective equipment being diverted from mental health trusts away to general medical trusts. We knew that there was delays in access to testing, and so on. So there were many factors that played out that are kind of structurally embedded, that then sort of played out when the pandemic emergency happened. And we've done a piece of work funded by the Health Foundation, which is a mixed method study to try and understand this a bit better. And this transcript comes from one of the interviews. So Josephine Oklu, my colleague who led the interviews with peer researchers, with interviewing people with severe mental health problems across the UK. And the reason why I've included this is because I think this excerpt really just highlights all the multiple overlapping forms of discrimination that play out. And so what this person is really highlighting, and I won't read it out, but what this person is highlighting is that it's not just race, it's other elements. There are unconscious biases that play out. And on top of that, people, that this participant is aware of the dimension of social class playing a part, as well as gender, and then her own experiences of having been in care coming out and almost being re-traumatized by the very interaction that is meant to be helpful and supportive. And so this is work that's currently in prep, but in some ways this kind of picks up very clearly, for me at least, that the way that discrimination and disadvantage overlap and have their own impacts. So I'm going to conclude there, and I'm just going to conclude with a reminder that there is a 15 to 20 year reduction in life expectancy with people with living with severe mental health problems, and this is on par with the gaps in life expectancy that we know happen for other socially excluded groups, and is experienced by racially minoritized people to a similar degree. COVID-19 definitely laid bare to these deep-seated inequities, and I think moving forward, we really do need to be thinking about intersectional and overlapping forms of disadvantage and discrimination and how they play out in terms of impacting people's health. And I would argue strongly that mental health really does require additional consideration. I didn't say it at the beginning, but I mean, one of the other elements that I think, again, Habib picked up is that, severe mental illness might be overall rare in the general population, but we know that people from racially minoritized backgrounds are disproportionately impacted by the adversities of living with severe mental illnesses. The 2018 review, Mental Health Act review, that highlighted higher levels of coercive pathways into care and lower levels of access to evidence-based treatment. So mental health really does need to be considered when we're thinking about multimorbidities. And I'm just going to end there with a quick thanks to the various funders and supporters for this study, and of course to our wider research team, which included peer researchers. Thank you very much.
We have it pressed for time, so I'll just hand them quickly to Eve.
Thank you, Laia. I'm just going to try and share my screen. I think Jay needs to stop sharing hers first, if that's possible.
Does that work?
Yeah, thank you. I'm just going to try and share mine now. Yeah, so thank you so much for the invitation to join you all today. My name is Eve Riley. I'm a policy lead with the Richmond Group of Charities. And we work together to collectively represent more than 15 million people living with long-term conditions. And we add value by working together to address issues that we might not be able to address as effectively as individual charities. So we focus particularly on the needs of people with multiple long-term conditions. So in my presentation, I would like to share some of the work that we've done through our coalition on multiple conditions, but particularly thinking about how it relates to issues of health equity. So as Dr. Hyanga and other speakers have so powerfully shown, the picture is complex, but the socially patterned nature of multiple conditions is really clear. So we see multiple conditions track intersections of race, of age, of ethnicity, of income, of geography. And we know that people from ethnically minoritized groups carry some of the highest burden really in terms of multiple conditions. And as others have said, the pandemic has very sadly put a spotlight on that and also accelerated it too. So it means that people of non-white ethnicity arrive at multiple long-term conditions earlier, and that they are then living longer of their shorter lives in ill health. And I think as the other speakers have really powerfully articulated, this is a social justice issue. And we think the multiple conditions lens is a useful one to think through this complexity, because as Dr. Munchi was just saying, you know, taking an intersectional lens to the ways our social identities, like our conditions, are multiple. So multimorbidity as a lens on some of these issues can help to expose how overlapping social structures are actually upholding this very unjust health gap. So set against that big picture data, I'd like to share with you some stories from a piece of qualitative research we did at the height of the COVID pandemic. This was commissioned by the Richmond Group in partnership with Impact on Urban Health and the Royal College of General Practitioners. And our starting point really was an awareness that a lot of our understanding is limited by a lack of data. So just as people with multiple conditions are disadvantaged by the inverse care law, there's also an inverse insight law in operation. So whilst there's no lack of evidence that there's a huge problem, there is less insight into what we do about it from the perspectives, particularly of those people most impacted and those communities most impacted. So, you know, there's a really urgent need, I think, to normalise applying a race equity lens, an ethnicity equity lens, a socio-economic equity lens to this data, but also to think about whose voices are missing from the existing evidence base. And alongside that, whose voices are missing in terms of sense-making and interpretation of the findings. So for this piece of work, we interviewed a total of 52 people, both patients and professionals. And we chose the people because they brought to life a range of different factors associated with health inequity. So people of different ages, different class backgrounds, different ethnic groups. And we also included some people from what we refer to as inclusion health groups. So we spoke to refugees and asylum seekers too. So I'd just like to introduce you to a few of the people who were generous enough to share with us their experiences. So this is Bekele. He's a British Somali man living in his mid-20s in Balsall Heath in Birmingham. And Bekele lives with severe asthma and type 1 diabetes, which started in his childhood. And one of the issues that others have talked about is this issue of distrust and disconnection, and that was really big in Bekele's story. So he felt that the professionals he interacted with were quite socially disconnected from communities like his own. He described a kind of oversubscribed local service that was was very stretched in terms of waiting times. He felt it was low quality, and he even described an air of hostility from some of the professionals he was interacting with. Bekele's mum also has type 1 diabetes, so helped him to learn to manage his condition from a young age, but his mum doesn't speak very much English at all and found it very difficult to communicate with doctors. And Bekele remembers feeling like the medical professionals that he interacted with weren't taking her seriously, and that he would often have to jump in and try and advocate on her behalf as a young child. And so, as I say, this theme of disconnection and distrust really runs through the report. And that mistrust was an issue for Kumar too. So this is Kumar, a 40-year-old man of Indian heritage living in Stockwell in South London. Kumar is a parent, and before the onset of his multiple conditions, he worked at IKEA customer support. He had a busy social life. His conditions include ulcerative colitis and type 1 diabetes. And Kumar's distrust really related to the fact that he didn't feel the professionals he was dealing with were helping him to understand how to manage his conditions. So, for example, he describes the ways he often ended up in hospital due to low blood sugar, and he was given Lucozade in the hospital. So he came away feeling that Lucozade was the best thing to drink, best medicine for his diabetes. And it's only very recently that he realised that that wasn't the case. And as a consequence of his conditions, he's had to stop working, which has placed quite intense pressure on his family caretaking system. And I think for many of the people that we spoke to in this report, they felt that the system was set up for very confident individuals who were quite driven to get the help that they needed, and that they felt that they had a sense of agency over their own health. I think for many of the people we spoke to, though, they didn't feel able to push for the help that they needed. And in Kumar's case, that led to multiple emergency admissions for his diabetes that would have been preventable had he had the right sort of support to self-manage. And then just finally, I will share with you a story of Vera. And I think Vera is a really good illustration of, if you stay very close to the source of people's day-to-day interactions with the healthcare system, you see that often the kind of help and support that is needed isn't biomedical. So for Vera, she's a 74-year-old Portuguese woman living also in Stockwell in South London. She has angina, type 2 diabetes, kidney cancer and dementia. And she also struggled greatly with what the research team felt were undiagnosed anxiety and depression. And this issue of mental health challenges, from the very severe and enduring mental illness to more low-level depression and anxiety, is a consistent theme across the report and across our wider research. I really think mental health is a huge issue. And we know that's borne out in the big data. You know, people with multiple conditions are at a much higher risk of going on to develop a mental health problem if they have physical health problems, and the reverse is true. And we think this is likely because of the mutually reinforcing and complex ways in which the pressure of ill health interact to some extent. So, you know, the pressures of life make us sicker, and being sick adds to the pressure of our lives. I think more positively for Vera, there was a really strong practical service offered for the local Portuguese community. So once she was plugged into that, she got help with things like her housing, she got help with her health administration, she got cancellation services for her appointments. When she needed surgery for her cancer, she was able to get an assessment from the district nurse to check and adapt the suitability of her accommodation and so on. So she really demonstrates the value of a very highly personalised, needs-led, in the jargon, sort of whole person, or you know, a service that's able to see her in the context of her whole life. But even within the same report, there were two other Portuguese participants who showed that the service is very geographically bounded. So when they moved away from the area, all that support fell away for them. And also Kumar, who lives in the same postcode, you know, isn't getting access to that particular offer, and therefore not getting the support to manage his diabetes that he needed. So that's just a flavour of some of the stories in the report. And I just wanted to wrap up by sharing the Multiple Conditions Guidebook. So this was another report that we put together, which identifies 10 case studies of good practice with principles for local service offers. And they all share a focus on building relationships with grassroots communities outside of NHS services, building relationships with organisations who are trusted by their local communities. And I think crucially, they share a principle of equity by design, not just access to services. So rather than doing to populations, these types of approaches have been developed in partnership with communities. I think it's important to say that these services often require infrastructure funding to be sustainable, because as well as the inverse insight law that I mentioned, there's definitely an inverse funding law in operation in the community sector too. And I think nothing that I've described here is going to end the structural racism and other discrimination, that we are faced with here. These systemic problems call for systemic solutions. And that's where I think some of the approaches that have been described that have larger missions that can kind of tackle overlapping systems of disadvantage can succeed in tackling multiple equity goals at the same time. But I think at the same time, for me, what was quite powerful about this work was that as much as social factors are hastening people's journey towards acquiring additional illnesses and having multiple long-term conditions, multiple conditions can then further entrench disadvantage. So I think there is a lot that can be done to make sure inequity isn't reinforced, however inadvertently, through health and care systems themselves. So if we think about, for example, administrative and treatment burden that increases people's out-of-pocket costs in terms of travelling to lots of different fragmented appointments, or clinics not being arranged outside of peak travel times, or lack of availability of culturally sensitive services, or efforts not being made to group appointments in a way that works for people around their work schedule. Those simple or quite small strategies can have actually quite profound effects and set in motion practices that can begin closing this very unjust health gap. So I will leave it there, and thank you very much, and I look forward to hearing from the other speakers.
Thank you. That was very useful and very interesting. On the topic of funding and how unequal this is, I want to link it back to Jay's point about lack of funding in mental health, particularly with severe mental illnesses, which disproportionately impact minoritized ethnic groups. And I think that is one of the ways in which structural racism operates, so by unequally distributing funding. Yeah. So I'll pass it now to Mai for the next Q&A session.
Yeah, so there's a couple of specific questions that have come up, and then maybe we can pick up that point that you just made then, Laia. So Eve, I don't know if you want to say a bit more about the issue of trust, because that came out in your presentation. It was something that Habib was talking about earlier. Do you want to say anything a bit more about sort of trust as a determinant of health, and whether that sort of came out in your work?
Yeah, I mean, I think it's just a really important point, and it runs through all of the examples in the case studies. As I say, people's sense of disconnection from local service offers was really profound. I think one of the recommendations we make in the report is for services to have a think about how much they know about who is, I guess, worry about who isn't accessing your services, as well as the offer for who is. And if people, how do your local service offers map to the types of people that live in your local community, and where are the gaps? Yeah.
Thanks. And yes, then also a couple of questions about sort of faith and religion and how those might play positively or negatively into some people's experiences of healthcare. I don't know if there's more you can say from your interviews there.
Yeah, I mean, I think in the report we touch on that as being really important for certain communities, in a really important way into building relationships and connections. I think we saw that in the pandemic a lot. I don't think it's so much in this report, but we did some other events looking at outreach work around vaccines, for example. and there was some really interesting work in Tower Hamlets, which was my local area previously, where people were going out into mosques and other places of religious significance to people to talk through trusted faith leaders about misinformation or hesitancy, and also to deliver things in those settings as well. So going to where people are rather than having people come, and that was really powerful. So I think building those types of relationships is really, really important.
Thanks. And then Jay, one quite specific question, maybe a bit more about why type 2 diabetes is so strongly related to mental disorder, but then maybe a sort of bigger question about to what extent some of the inequalities that we're seeing might be due to sort of structural racism, institutional factors versus individual behaviours and cultures. I don't know if there's something you might want to say on that from the quant or the qualitative work.
Yeah, sure. I'm happy to. I think I gave the example of diabetes as one example, but actually, if you look, this is where multimorbidity is very important, because actually many conditions co-occur, and it's not just diabetes. So we find that things like cardiovascular disease, ischemic heart disease, and so on are just as important. I just use that as a kind of example of one condition that's particularly salient for people living with severe mental health problems. I guess it goes back to what Habib was saying earlier about the causes of the causes, right? So essentially, we know that deprivation and other indicators of disadvantage are fairly strongly linked to diabetes prevalence. Lara and others have done work sort of highlighting the impact of racism as well on physical health. And when we think about people with severe mental health problems, the similar sorts of factors are still at play. They don't disappear, they don't become different. And I guess what I was trying to say is that they take on a different sort of, we have to add that in to the lens of thinking about inequities, and particularly when we're thinking about severe mental health problems. If we think about conditions like psychosis, they come on in people when they're usually young adults, at a point when they're just about to leave home, they're just leaving, might be starting work, and they can have quite a massive impact on people, which then on top of that, if you think about how stigmatized sometimes these conditions are, brings added challenges. And then there is a bit of work that suggests that people might then drift down into areas that are more deprived and be less, and that will then have a sort of impact in terms of their socioeconomic position. So this then adds another element. So I'm giving a very long-winded account, but I mean, in effect, I'm saying that a lot of the factors are interlinked, but it's always helpful to go back to that larger picture to try and sort of understand the specifics. I can't remember the second bit of the question. You said something, May, as a second question.
This is quite a big question. About to what extent inequalities are about structural racism, institutional racism, or are they more about individual behaviours and cultures?
I mean, I think that when we're thinking about the structural, it's not one or the other. It's going to be a complex nexus of so many of these interacting factors. And and I think Laia raises a really important point that these structural inequities come out in terms of funding mechanisms, in terms of the attitudes and behaviours that healthcare professionals might have. Not even asking about, sort of mental health, for example, could be one way that sort of biases play out if we think about that. But then also in the excerpt that I shared, just people's implicit assumptions of the person that they're seeing in front of them when they're providing care, and then how that then plays out. So it's not one or the other. I think it is it could be something that we pick up as a wider discussion. There are so many different elements of this, and I don't think it is just around one. But I think if we go back to this bigger question about structural processes, and how they then almost kind of have an impact far down the kind of the sort of the framework, right down to kind of some of the sort of proximal experiences that people experience when they're trying to access care, you can see it just plays out. So it's a really big topic, and I think you could sort of, for each, if you took any condition, you could essentially play out and try and understand where these different elements have an impact, and use it to maybe try and even think about how you would tackle improving care.
Thanks. I think that's a good point to hand back to Laia for the next speaker. Thank you.
Yes, thank you. I think I just want to add, in the discussion of structural and ethnic inequities, that we often put deprivation at the individual and area level separately. But structural racism is one of the key drivers of ethnic inequities and deprivation and individual level socioeconomic inequality. So I think we have to bring it back into the discussion of ethnic inequities and how structural racism is leading to, as Jay was saying, minorities and ethnic groups are more likely to live in areas of high deprivation. They're more likely to be socioeconomically disadvantaged. And this doesn't just happen by chance. This is driven by structural factors. So I think this needs to be incorporated back in the discussion. And with Javier, we have published a policy briefing on this discussion exactly. So I think it's a nice leeway into Javier's presentation. Not that you will mention this, Javier, but just to introduce you.
Thank you, Leah, and thank you, everyone. If I can just hopefully you can all see that screen.
Yeah.
So the challenge with being the last speaker of a session like this is, what else is there left to say? Some of the brilliant presentations that we've had already, some of the wide-ranging focus on inequality, particularly racial inequality, and the complex way that it's been done, leaves perhaps me with a very difficult task in reflecting back on that. But hopefully what I've got to say in the next 15 minutes or so will perhaps add to that discussion, and perhaps may also explore some of the points that have been raised in the Q&A. But if I can do a little bit of advertising first and tell you a little bit about the Race Equality Foundation. We're a national charity that's been around for about 35 years. We're looking to promote race equality and social support and the provision of public services. We've done this through exploring what's known about discrimination and disadvantage, developing evidence-based better practice to promote racial equality, and then disseminating that through educational activities, conferences, written material, and website. And if you go onto our website, you'll see that briefing that Leah mentioned just now, which we published a couple of weeks ago, looking at racism and how it drives health inequalities. Importantly, we're members of a range of networks, from the Health and Wellbeing Alliance to a recently established Alliance for Racial Justice as well. And we're also the organisation behind a parent education programme called Strengthening Families, Strengthening Communities. A little bit about some of our work. In terms of health inequalities, we've spent quite a lot of time trying to use evidence or develop evidence to better understand what needs to change and how we achieve that change. So just before the pandemic, we carried out a project that looked at developing a community-based approach to improving blood pressure monitoring. We know that the Caribbean community is particularly at risk from high blood pressure, and unfortunately, because of failings in our prevention, those communities tend to be diagnosed later, and inevitably the outcomes are poorer as a result of that as well. And a community-based approach was used to try and improve the access to blood pressure monitoring, including improving monitoring carried out by members of the community themselves. We continue to publish briefing papers on a range of issues to do with health, but we've also published other much longer pieces, a review of the literature on racial disparities in mental health was published. More recently, we've started to looking at health checks for people with severe mental illness, a point that Jay has raised as being key in trying to think about what we do that's going to make an improvement. As importantly, we've published a series of briefings as part of the Race Equity Collaboratives work, looking at the impact of COVID-19 and thinking about what should happen next. And this work was funded by the Health Foundation. One of the frustrations then of doing this via Zoom rather than being in the room with you is that I wanted to put this acronym up and ask which of you recognize this and remembered what it stands for. Unfortunately, we can't have that interactivity at the moment, although some of you may be shouting at your screens that you do know what it is. But this was the acronym for New Commonwealth and Pakistan. The reason it's of significance is that this was the data set that we had to use before the 1991 census. We looked at who the head of household and where they were born, and from that try to derive some understanding of the size and complexity of Britain's Black, Asian and minority ethnic populations. It was clearly problematic from the day we started to use it, and it increasingly became less and less useful as part of any analysis. And what today's demonstrated is the incredible change that has taken place since the 1991 census included a question on ethnic group. The types of analysis that Brenda, Jaya, Emily and Habib have highlighted could not be possible without that specific change that took place in 1991. Perhaps it didn't go far enough. Certainly the discussions before that question was put in the census was to try and have a more complex understanding of identity that recorded religion, as well as language. But then that didn't happen until later on. So it's in 2001 that the census finally starts to record religion and faith. And it's not until 2011 that we start to record language, although we end up focusing on English proficiency, not just language spoken. Inevitably, with that inclusion of the ethnic group question in the census, there's been an explosion of administrative data, and we've seen again how that can be used and how that provides a real insight into some of the experiences. And Brenda's focus on multimorbidity is again a demonstration of the value of that recording of ethnicity and administrative data, particularly if we're trying to understand what it is that we need to do to change healthcare provision to actually improve it and its significance. A number of the questions in the Q&A have highlighted the intersectional analysis, but a number of our presenters have shown the intersectional approach that they've used as well. But it must be recorded that one-dimensional analysis persists to this day, and we still have studies that perhaps fail to understand the complexity of people's lives. But perhaps the way we've seen, another change that we've seen is the shift in mainstream analysis and understanding. And we can look at Michael Marmot's two reports on the wider determinants of health inequalities. The 2010 report hardly mentioned ethnicity at all. I can't even recall whether racism is mentioned in there in any way, shape or form. Quite out of step with what Donald Aitchison did in 1999, but nevertheless a demonstration of how race and racism wasn't perhaps being taken seriously by mainstream understanding of health inequalities. But by the time the 2020 report is published, there's a dramatic change where Marmot regularly highlights the racial inequalities, including pointing out that for perhaps minority communities, including Gypsy, Roma and traveller communities, the inequalities, the the rise in inequality over that decade has perhaps been worse for those communities. We still have gaps. There's little data or analysis on LGBTQI communities and from Black, Asian and minority backgrounds, and perhaps some of the changes that are going to result from the inclusion of new data in health data sets will perhaps bring some change there. However, challenges on data and analysis persist. We've recently published a report on issues around the accuracy and coverage of ethnicity recording within health data sets, and you can find that on our website. The role of socioeconomic status as a controlling factor is sometimes has been demonstrated to be done very well by some of the presenters today. But there's also many examples of it being done poorly. For example, the Timpson review of social exclusion tried to explain away racial inequality by constantly referring to socioeconomic status, and ends up actually concluding a set of actions that only in a minor way address racial inequality rather than what it was meant to do. And many of you will have seen Inclusive Britain, and its approach to the data analysis has challenged our notions of disproportionality and whether or not it's a useful way of thinking about how racism has an impact. And it's a real worry because it's a government-led response to the CRED report, and is one that will see much of the work that we do responded to. But what has changed? It's important that we're not only describing the problem, but trying to think about how that problem needs to change. And it's important to acknowledge that even in the last 10 years, 12 years, there has been change. The new health inequalities duties enacted in 2012 and 2022 are perhaps one sign of that change. For us at the Foundation, the 5-year forward view for mental health was groundbreaking in terms of a national wide-ranging attempt to address racial inequality in mental health. It talked about prevention. It didn't only just talk about treatment. It talked about some of the changes, however, that needed to take place in treatment, including in how we implemented the Mental Health Act. And was in many ways a game changer in trying to integrate a racial equality lens into challenging the poor provision of mental health services. But however, what we've seen, and Wesley's review of the Mental Health Act demonstrates that many of the challenges that we've been identifying for the last 20 years in terms of Black, Asian and minority ethnic communities' experiences, particularly African Caribbean men's experience of the mental health system, persist to this day. There has been limited change over that time. The NHS long-term plan, again, was perhaps another high watermark in terms of addressing racial inequality. It contained key commitments on addressing racial health inequalities in the provision and experience of care. And there have been some key developments as a result. The Core 20+5 approach that's been led by the Health Inequalities team at NHS England clearly seems to have generated wide-ranging work across the system in trying to address racial inequality as well as health inequalities as well as a whole. But progress has been patchy, with some commitments already withdrawn, such as the continuity of care in provision of maternity services. A key commitment made in 2019 that by April 2024, 75% of Black, Asian and minority ethnic mothers would have continuity of care during their pregnancy, was withdrawn last August with very little comment and very little challenge as to why that was. And it's a sign that when we try to progress racial inequality, it's perhaps not as straightforward as we would think. Habib and others have already mentioned the Sewell report, but the real worry is Inclusive Britain and what it says about our attempts to try and try and bring about change in the experience of healthcare itself, but also in terms of the wider determinants in there. In an article I wrote about it, I pointed out that virtually none of the funding commitments in there are actually new commitments. It's the rehash of money that was already allocated to addressing a change that's now suddenly being branded as being part of an attempt to develop an inclusive Britain. And those who hoped that the levelling up agenda would perhaps try and bring about that some change will have seen that it's often been more a superficial attempt to improve the high streets of poor areas rather than the experience of those people actually living there. And unfortunately, what we've seen is that the workforce issues that we've been documenting for a number of years have persisted and may have deteriorated, even though the workforce race equality standard is there, and in some senses is perhaps groundbreaking in the approach of an organization as a whole, but particularly a health service trying to improve the experience of the people that they employ. So perhaps a comparatively depressing picture of where we are, even though we've seen a dramatic improvement in the data that we gather and the analysis that we're now able to do. So what needs to be done? I'll echo some of the points that have already been made today about the need for more data and better analysis, although I would caution against suggesting that in itself is going to bring about change. Certainly the better use of data is going to be key, and I have to congratulate those people who've been developing the health inequalities dashboard. I've been involved in a number of attempts around developing dashboards such as this, and this is the first occasion I've seen something that seems to be genuinely useful for the health system locally and regionally to understand what's going on in their area, how it compares to others, and what it is that perhaps they need to do to address some of the inequalities there. Whether or not it actually delivers on that, I suspect is down to other things that need to happen, but it's certainly a valuable way of trying to use data better. Better engagement with communities, however, is something that is key, and we've already heard some call for that. That discussion about trust is part of the issue, but as we've seen in the last couple of weeks, part of it must be the reframing of that conversation of race inequality and the actions that support it as well. It's fun. We find ourselves generating a lot of heat at the moment around issues to do with racial inequality, rather than generating light and addressing those inequalities and trying to bring about that change. Somebody in the Q&As raised that issue about prevention, and it's quite right that we do need to invest in prevention, but as the Health Foundation has repeatedly demonstrated, that over the last 10 years we've seen a dramatic decline in the investment in prevention through the public health grant. And not only is it often announced very late in the day, it's been cut dramatically over that period. But as the Health Equals work and the Health Equals campaign has started to highlight, part of the difficulties is that as soon as we start talking about prevention, we end up talking about the decisions individuals make, rather than focusing on the structures that impact them. So when we start talking about obesity and preventing it, almost always people start talking about individuals making better choices about what they eat and the exercise they do, without recognizing that both those things are dramatically impacted by the structures around them. Many of you will have seen a report today pointing out that the best value food available from our biggest supermarkets tends to not be available in the small shops that are around in deprived areas. It tends to be available in the big supermarkets where poor people rarely go to shop. So it's those structures that we need to focus on, and we need to understand how those structures have an impact. We certainly need to reframe the policy conversation, and Leia's reminder about racism being a driver of inequality is an important part, but also that it's not ethnicity that drives inequality. So, for example, we've spent a little bit of time looking at the low rates of take-up of vaccination programs such as HPV and so on. The majority of the research we've seen around that focuses on the decisions that individuals make, particularly parents make, as to whether or not their daughters in particular are allowed to take up the HPV vaccination. Very few of those studies look at the healthcare system around them, even though we know that GP practices in deprived areas tend to struggle to implement vaccination programs effectively, in part because they get less money. So, we're not addressing the structural factors. We end up focusing on decisions supposedly communities make, rather than seeing racism as the impact, as part of the driver of that experience. And the final thing is that we need to fix the broken government approach to racial health inequalities by developing a national race equality strategy. We've already seen, and Jay's presentation, and in particular has emphasized that if we wanted a demonstration of how racial health inequalities are not seriously taken by the government, the pandemic is an exemplar of that. The many warnings that were issued by organizations such as ours at the beginning of pandemic were not listened to, and therefore we implemented policies that didn't protect Black, Asian and minority ethnic communities and other poor communities against the impact of the pandemic. So you say to people, work from home, even though Black, Asian and minority ethnic people are in jobs that they cannot do from home. They're more likely to be working in care. They're more likely to be working in health services. They're more likely to be working in factories. And how do you expect them to do that from home? You then say to them, isolate at home, when it's more likely that they're going to be living in overcrowded conditions, more likely to be living in high-rise blocks, less likely to have access to green space, less likely to have access to public green space at the same time as well. And so those strategies didn't protect those communities. And perhaps worst of all, the rollout of the vaccination program again didn't take into account racial inequality. We decided to prioritize over 80s in the rollout of the vaccination program, even though of the 4.6 million people over the age of 80, only around 140,000, 145,000 of them were from Black, Asian and minority ethnic communities. And we had the situation where comparatively well-to-do areas such as Surrey were getting more vaccine in the first month than comparatively poor areas like Lambeth or Tower Hamlets. So we require a health inequality strategy that understands how race impacts and has that impact. It'll be interesting to see whether the approaches such as the Wellbeing of Future Generations Act in Wales is something that we can learn from. But certainly we need to think seriously about how we address these issues in the future. Do go on to our website for some more information. And if you're able to, do join the Health Equals campaign as well. Thank you very much.
Thank you, Javier. That was provocative and a bit frustrating, I think is the word. But yeah, I'll give it to Mai for a second. I think we only have 5 minutes for final Q&A, but I wanted to link your presentation, Javier, to Habib's presentation at the beginning, because you both mentioned something around what needs to be done in order to address ethnic inequities, and you have both focused on the structural factors, racism. And I think, what needs to be done, you mentioned before, what do we have to do differently to ensure social action takes place? And I wonder whether you and other members of the panel could say a bit of what do we need to do next to think about prevention and treatment around ethnic inequities and multiple long-term conditions that we haven't done now, or that we haven't been able to do effectively. Okay. And maybe Mike can bring in some questions.
Would you like us to answer that? Yeah, so I can start with my view on that. I think looking forward, looking ahead, we've obviously got the major conditions strategy forthcoming, but the point that we've raised at the observatory, particularly in an opinion piece which was published by the BMJ just over a week ago, and it doesn't just relate to the major condition strategy, but any intervention that focuses on deprivation or the 20% most deprived only, is that deprivation will tell you where the inequality exists, but it won't tell you why it exists. And therefore, focusing on the key elements around racial structural inequalities is absolutely critical for us to have a meaningful go at tackling these issues. Otherwise, in 2 years' time, in 5 years' time, we'll be having a very similar webinar as to this one. The other point is that where tackling racial inequality becomes an option, then very often, from my experience of working in this area for just over 20 years, it's an option that leaders will brush under the carpet or not want to deal with because it's a difficult thing to deal with. And therefore, there needs to be a level of accountability around this agenda as we move forward. Yes, golden threads throughout strategies and things are great, but there needs to be a concerted focus on race and racial inequality.
Leah, if I can come back and build and echo much of what Habib and others have said, there's clearly an opportunity here to deliver behaviour change as well as part of our strategy to address racial inequality, and the work that people like the Caribbean and African Health Network in Manchester are doing, or Croydon BME Forum in Croydon are doing, are really very vital ways of getting people to think about some of the behaviours that they could change themselves to improve and protect themselves against poorer health, or perhaps better manage the poor health that they're actually experiencing as well. However, those things aren't going to achieve the sorts of change that we need to achieve. We've seen the shocking example of Abhishek's death as a result of living in a moldy flat, but actually that's part of a wider problem that we've got in terms of the poor quality of housing stock, particularly in where Black, Asian and minority ethnic communities live. And it's true even when they're living in owner-occupied accommodation as well, that it tends to be of the poorer quality and be older as well. And that can only change in there can only be the result of structural change, the building of new social housing that's affordable to the communities that currently live there, as opposed to pushing communities out of places like Haringey or Tower Hamlets or Camden into other areas. We need a social housing program that really addresses that. And the other part of a good quality social housing program is that it will drive up the standards in other areas included in the private rented sector. And again, it's something that can only be achieved because we know it was only achieved through government action in the 1950s and 1960s. It wasn't the private sector that did it. It was the government and local council, through local councils, that led to that incredible change in social housing in that period. So that's why I think we end up focusing on, yes, let's talk about behavior change, but without addressing the structural factors, we're not going to achieve the scale of change. And if I can just add my final bugbear, is that we're spending more and more money on treatment. It's not enough. I don't doubt it's not enough, but we're spending more and more money on treatment. And the reality is that we will never have enough money to spend on treatment if we don't address prevention.
Is there anybody else from the panel want to do this? Otherwise, I'll send to my.
Okay, I'm just going to summarize. There's been so many excellent questions, and we don't have time for answers now, but just sort of 3 questions, challenges from the participants. Thinking about how we ensure people are actually treated when they get an illness, when that illness is identified. How do we then make sure that they get treatment, that they follow the treatment plan? Something about sort of coordinating care between the NHS, lots of other organisations, and then the individuals living within those circumstances, difficult circumstances and disadvantaged conditions. Then the second point, we have the statistics. We know the inequalities exist. We know that they play out individually and systemically. But what about action? What resources are we putting into our healthcare system, our hospitals, mental health communities, primary care networks, and so on? And accountability seems to be lacking. So I think they're a challenge about what resources we're putting into healthcare and how those might be sort of tailored to addressing ethnic inequalities. And then a final point, which is kind of on generating the evidence, making sure we're asking the right questions. And the point that academia is highly inequitable as it stands, and it doesn't include minoritized groups at senior levels. And so how are we going to drive approaches to addressing inequities in health and care, given that kind of lack within the academic community?
Thank you. So these are questions or points for further thought. Or do you want anybody to answer in particular?
I think there's not time, so I think we'll take those as challenges for us each to take away.
Okay. Yeah, so I think you're right, Maya, that we have hit the time mark. So I like to thank all the speakers for the really incisive and important presentations. And thank you for joining this event. I like to say a final point about prevention versus treatment. And if we think about the causes of the causes, and thinking about ethnicity, the key cause is racism. Addressing racism addresses the targets prevention, but also treatment, because the drivers of unequal treatment are the same of the drivers of the structural determinants of health to begin with. So I think there is a point at which prevention and treatment converge, and it's at the causes of the causes. So I think there's a added value to addressing this, that it's not about just prevention, but treatment as well. So yeah. So with that, I want to thank you again. I hope you found this interesting and engaging, and many people have asked about circulating slides, so I will ask the presenters whether they agree, and then we will send them around. So thank you very much again, and have a good day. Bye.